just a little bit of background. So my name's Catherine Dampney. I'm the Director of Innovation and Transformation for BI at SCW. And I've worked in a number of roles, but principally one of the ones that I've enjoyed the most, but I found the most challenging, was as Chief Information Officer. I have been a Director of IT, and now I focus specifically on digital and data solutions for population health management. My colleague who will be joining us in a minute, who's just slightly delayed getting here, but I'm hoping he'll come to talk to us, and is Dr. Mark Farr, and he is a Chief Analytical Officer for the Kent and Medway ICS. He has numerous illustrious backgrounds. He's been a director at Dr. Foster's, one of the original founding members. He chairs the Regional Analytics Board. And all in all, a glorious and very interesting background. And if you haven't followed him on Twitter, I encourage you to do so. So why are we here today? What I want to talk to you about, or what we really want to hope to persuade you about, is the challenge that we have facing us at the moment in terms of the key drivers for population health management and the key enablers, particularly around technology and digital. So for those of you who work in this area and who have their speciality in digital data and technology, you will have noticed that, or I hope you've noticed that there is a proliferation of roles these days. Previously, when I started as a CIO 5 years ago, there were CIOs and there were IT directors and there were directors of informatics. But now we have chief digital officers, chief nursing information officers, chief clinical information officers. And I think the question that raises in my mind, and has raised in a lot of people's mind, is why? Why are we getting this proliferation of roles, and what's the cause? And are these the right roles, and have we got enough of them? So let's talk about the CIO role. This is my particular area of expertise and my particular area of interest as well. So I would say that in my experience, and I've been a long time in the NHS, but over my illustrious or not so illustrious career, the landscape has changed significantly. So when I started in the NHS 15 years ago, I can honestly say that our life was focused around boxes and wires. And if anything, one of the key things was there was not much to it. It was quite a simple little life. You keep GPs plugged in, you provided people with printers, you wrote strategies, you had corporate systems. There were some information analysts somewhere and they had a lot of spreadsheets, but that was pretty much what there was. And one of the interesting factors that I noticed then when I joined the NHS was I was very, very surprised at how much of the NHS ran off the back of spreadsheets. So coming from a financial institution backgrounds, I was used to using bigger data systems and bigger data platforms, and I did notice that was one of the key features when I joined. So we're in the middle of MP Fit 15 years ago, and everybody who went through that probably still bears the scars from it, and not an area we want to revisit, but we got into the fantastic one size fits all. But I think we've moved on from there. So let's go forward to 10 years ago. At this point, MP Fit has disappeared, but integration is becoming ever more important. Sharing information between clinicians, creating shared cared records. Well, I started to work very closely with the Hampshire Health Record, which was one of the first of its kind to create a regional-wide shared view for a clinician, for a patient. Cutting edge stuff at the time. We were seeing more integration and we were seeing more movement for care in the community. Mobility became important. Sharing data and integration was really critical. And then again, moving forward, so we get to 5 years ago when I became the CIO. And at this point, the phrase big data has popped up on the horizon. So the shared cared records are creating a significant amount of information but almost as a byproduct. But certainly there is a need to derive more intelligence and understand what is happening in the system. System integration is more important than it was with the rise of the ICSs and population health management. Patient access is coming up the agenda as well. All in all, what you're looking at here is an increasing level of complexity and more stuff arriving on the plate. Okay. So where are we now? Just thought I would bring a picture here that really illustrates what's happening. What you're looking at in these two pictures is probably a common look back and a look forward to the here and now and where we were. So same place, different timescales. So 1890. This is actually a picture of Los Angeles. So that was it. Some fields, some farmsteads, 50,000 people, which is about twice the size of the place that I live now. Right now, where are we? 13 million people. So what does this actually mean? What you're looking at, it's not just more people and more land, but it is an increasing level of complexity that we're facing in this environment. And I think that's been very much mirrored in my experience as a CIO. So what we're seeing now is that we have moved from what was essentially a very simple context that we were working in. You may think it was different, but I think this is probably my personal experience. Technology was a constraining factor. We were limited by the technology that was there. We couldn't use the data in the way that we wanted. We couldn't share the data as much real time. We couldn't provide mobile devices to suit every environment. We were very much focused on the needs of the organisation. So it was about patient flow, PAS systems for hospitals, GP systems to support GPs in the way they worked. It was a really siloed approach. And as I say, data mostly was starting to be a bit of a byproduct. Apart from what was being used in the here and now for the workflow, the data that building up wasn't really exploited and wasn't really used. But where are we now? The picture is very, very much more different, and there is a contextual complexity which is creating a complex environment for any CIO and any informatics leader in this space. ICSs, population health management is itself, focusing on the needs of the person, focusing on a more holistic way on the individual, requires a much more integrated picture, not just around a care record, but about how the system operates, how multiple organisations share data, what they want to share, when they need it, how they need it. There is a strong drive, as you know, for system intelligence. There's a wash with data, it's sitting out there, but can we interpret that in a way that makes sense for us in terms of delivering healthcare and making decisions, from the patient making decisions about how to look after themselves, right the way to a strategic system decision about service redesign and development. It means that you must present the data in the right way and the right information at the right time, puts a whole load of other challenges in that space. Technology is by no way can we sit there and say the technology is the limiting factor here. We're far from it. Technology is absolutely driving change at an incredible pace. And when you look at what has happened over the last 6 months, with the advent of COVID and the drivers in the system, you will see some of the stuff that we've been trying to achieve for years has blossomed overnight. So the use of technology, interactions with technology, not just by clinicians in terms of remote consultations, but also patients accessing services through technology has become an absolutely driving factor in the environment we're working with. So where does this leave us then, or where does this leave you as the budding CIO or the CIO in the system? So one of the most important things I found about, or I would say, is you need the headspace to do your strategic thinking. If you are responsible for delivering strategies in these areas, you need not only a good team of people working with you, but you need the time and the space to work this through and understand what that strategy will be. It used to be that your strategy was a technology strategy. This isn't the case anymore. You can find landing in your boat, you now have data strategies, data quality strategies, architecture, data platforms, mobile strategies, governance strategies for all these areas. And then as important as that as well, you've got a workforce strategy. How do you create a digitally enabled workforce, not just your technicians, but for everybody? How do you create a workforce that is data literate? I can tell you now there are two solutions to this. You can get therapy because you will have run out of headspace for all this, or you need to start thinking about who are you going to work with and who your strategic partners are going to be to help you create properly integrated solutions that will enable all the demands that are coming through from you from the system. So this is I think this is me done. So this is a picture for me as a CIO. So now I want to talk to you about my partner, or my critical partner in this space. I would like to talk to you about a Chief Analytics Officer. So if I can hand over to Mark, perhaps you can explain how vital this role is, or we see this role in enabling all this to happen.
Okay. Can you hear me, Catherine?
Yes, I can hear you, Mark. That's great.
Okay, and I'm going. So I haven't set my status to available, but if someone can click the slides, I can talk. Is that okay? Thank you. Do you want me to do the biography bit? I apologize because I missed that, didn't I?
Well, I bigged you up, Mark.
Did you? Did you?
Yes, I did. I said how wonderful you were and what an amazing career you have.
Okay. Okay. I had a load of jokes for that bit. But I'll just make a start. So if someone doesn't mind going through my slides for me, the reason I'm late I was slightly late onto the call, I think proves the point of the call, that Catherine was helping me restart Teams, then restart my laptop, and I've still not clicked all the right settings in Teams. So for those CIOs or people working in that space on the call, hoping to learn anything about IT, that's Catherine's section. The second point I'd make in response to Catherine's slides, which look really good, is that I like Catherine, I've known her a long time, but I don't think you can just write data on a screen as though, and then presume to have given it as much detail as you like, which is your kind of point about therapy. And I do a kind of quite hackneyed joke now about big data being like teenage sex, which some people will have heard me say, which is that a lot of people say they're working in big data, and it is a bit like teenage sex, where everyone kind of, if you say you're working in big data, then people kind of go, oh yeah, no, I went to that big data conference as well. It was really interesting. There were some big pharma companies and Microsoft was snipping around and so on. And I just don't think you can do justice by rolling data into what traditionally has been an IT field. So I'm kind of here lobbying a point that that MRI scan that Catherine showed of the head, that showed sort of data and stuff near the top, my lobby point is to take that out and do it separately, because the world is too big to have enough headspace to do all of it well. And I'm kind of interested in a debate about job titles, which sounds really, really pedantic, but I think language is really important in this. And Catherine won't mind me criticising her and throwing around terms like informatics and digital and information and CIO and CDO and so on. And every trust you go into kind of handles these words differently. And I think it's really important. So you will learn nothing about me from IT on IT, The thing I'm really interested in is data and kind of drawing graphs. And I'm kind of pedantic about the language that we should use within this, which will kind of come out as we go through. So if we could go to the next slide. So I think I'm starting to make that point. And joking aside, of course, we need a good relationship. So I really like it that I know I can tell how many people are in my ED department at the moment by looking at my phone, but I need someone to work out how to get that onto the phone, because I've got no idea how to do that. I'm also, if I extend that, I'm really interested in forecasting how many more people might come today to our ED department. And that might be a really simple model, like the average of the last 8 Tuesdays, or it might be something much more sophisticated using triple exponential smoothing, because we're in a period of COVID and you probably need to take much more notice of what happened yesterday than the 15th of September 2019. How I get that data onto a phone is magic to me, and people like Catherine make that happen. But I'm really interested in that number being right. So on a kind of base of really good IT, I think it enables you to step up into that again slightly hackneyed kind of information intelligence into action. And those may seem like words, but I would encourage you, if you manage analysts, to challenge them along a continuum that top green box gives you. So if you imagine information might simply be a spreadsheet with rows of patients in it, intelligence might be that might be data, information might be putting that in a graph, intelligence might be putting SPC around that graph, and action might be actually annotating it and saying, at this point we made this change and this happened, and based on that there are now 3 really good recommendations. So IT and IM are separate things. If we go to the next slide, please. Ooh, someone's made my slides all fancy. I like this. This is brilliant. This is a great service. Okay, there was a slide that I provided which was much uglier than this and has since been improved here. And what I think you see through COVID is a huge opportunity to do 4 things quite differently. And I've listed these because I think they talk to IT, but only in passing really. And these 4 bubbles here are part of our new kind of COVID strategy of all the things that we think we could do. So, this is live for all of us at the moment. We're seeing infection rates going up very quickly. And we saw 138 people admitted to hospital across England last week with COVID, which was a big change on the week before, but about 1 a trust. So we're all sitting here wondering if that's the beginning of something or not, given everything that we've learned about COVID and how we've prepared our hospitals for second spikes and so on. And that kind of monitoring and forecasting is really critical at the moment. I came off a call this morning with our HSN, and we're putting a big bid together across Kent called Strength in Places, which is to build a kind of new linked data set and a sort of data academy for young data scientists. I think it's a shame that people study at universities across the south and then get on a train and go and get a job in a bank in London. And I think it's the job of people like Catherine and I to try and collar them as they think they might get on that train and say, well, why don't you come and work in the NHS? If you really like data, we've got loads of it. We've got absolutely loads of it. You'll need to talk to the stiffs in IT occasionally, but there's so much data there, and there's so much opportunity for you to use the AI skills or natural language processing as we move into electronic patient records, that you could have a really interesting career here doing something quite altruistic, and it's got flexible working and a good pension. So kind of come on in. So that's a list of things that we think we can do around COVID. And I put this slide up deliberately because it doesn't really talk about IT, but it kind of references it and assumes that you've got someone as good as Catherine to make it happen. So we've got on there KMCR, the Kent Medway Care Record. You'll be doing similar but different initiatives in the southwest and across South Central, where a clinician has all sorts of data about a patient in front of them without having to look through lots and lots of different computer systems. I'm really interested in grabbing that data, pulling it into a warehouse and starting to do predictive modelling on it, starting to do novel research, starting to link data outside of health. So we're doing some quite sensitive work around domestic abuse, and we've linked out to the police. So I had colleagues around me who had been trying for almost 2 years to get permission to link police data to ED data. So very crudely, the police have got a file of people who punched their wife, and I've got a file of wives that have been punched. And trying to get permission to link those two together has been quite difficult. Given the early stages of COVID, when we had a lot of press about increases in calls to domestic abuse lines, I managed to make kind of I'll call it an ethical argument that we should be allowed to get on with that. So we did look at the legal basis in terms of IG, and alongside that we made an ethical argument that this was the right thing to do. IT will help us by keeping that data safe and secure, pseudonymizing it, anonymizing it, and so on. But you ultimately need to develop a kind of research question on top of that. If we can go to the next slide, please. Oh, they've tidied all these up as well. Right. So I just thought I'd illustrate a few what it's like in my job. So that is my job title, Chief Analytical Officer. There's about 3 of us in the country, and I hope if we have this call each year, we'll gradually exponentially have more of us. And I would always lobby Catherine to come across out of the dark and into the light, and develop her career where all the cool kids are. So this is the type of stuff that goes on every day for me. So if you can kind of gradually, if you can click through to the next one. So I haven't checked who's on this call. I was desperately trying to figure that out, but my team's expertise doesn't extend that far. So I reserve the right to deny anything I'm about to say if anyone I know is on the call from Kent. These are real conversations. If we go to the next line. So someone reports into a coup, and then there's my reply, and it carries on. And again, so just stopping there for a moment. These are real conversations that you kind of need IT support for. And in this example, those conversations are so difficult that I had to avoid someone in the co-op and try and go anti-clockwise around the co-op instead of clockwise. Because I've actually got all the data in the trust, so I can put publicly for our patients how long waiting times are on each of our sites, and I can publish that for every single nurse on their phone if they would like to know which wards aren't quite as busy as they might say they are, and maybe we can sort of share some resources around. So quite interested in transparency as well. I'll give you another example. If you go to the next slide, please. Okay, so real example, the type of thing we get asked all the time. If you carry on. So if we just stop there, real example, and that was a real name I was called. Of course, I had to explain what SPC charts were to them, but someone died in an ED department, and this unfortunately happens sometimes. They're places where people go that are very sick, and unfortunately, it happens every year. So it's really important to work out when it's happening at a level that is different to what you might expect, and when it is normal variation. So based on this, we stopped a whole set of work streams starting up that probably didn't need to happen, and we had a sensible conversation with our CCG and put more things in place, but these things will happen. Okay, if we go to the next one. I think this is the last one. That's it. If you go to the next slide. There we go. So this is, yeah, these have got quote marks in because they're real things that real people said. So I think for those of you CIOs or CDOs or whatever you want to call yourself that do manage analysts, I think you need to be really clear with the people that work for you that they're not there just to keep them off the streets. They're there to, there's an expression in India about you either are the doctor or you serve the doctor, is the basic translation. And what this slide is saying is you are there to make data as simple and intuitive and accessible for people as possible. So don't hide it. Don't drone on about ClickView versus Tableau because no one cares. Just get the data out there, get it useful, get it statistically significant, get good data quality, as Catherine was saying in there, and actually offer some proper recommendations around it. Okay, if we go to the next slide. How are we doing for time, Catherine?
You're right. Okay. I think you're fine for time at the moment. You've got 15 minutes, and then we do some questions if anyone's got any. Okay.
So that was hopefully a little bit of useful context. Just sort of a very sort of up to date, a couple of things we're doing that might be of interest to people. Something I've kind of got increasingly passionate about, and just a bit of serendipity brought me back in contact with a friend from university who runs a thing called the Open Data Institute in Leeds, and I got asked to speak at a conference that they ran about a year ago, and I said, well, we'll call it something along the lines of Data Saves Lives, because I'm of the personal politics that in return for care free at the point of delivery, that I'm happy within reason to share my data and people use it to make research judgments on. So if Catherine and I both suffered from a very rare cancer, it's not unreasonable that we might over WhatsApp share our symptoms. We might even go as far as developing a spreadsheet and, you know, recording some metrics in it and so on. And I don't know if you can hear, there's a helicopter flying over me, but that'll go in a moment. I hope it does, unless it lands in the garden. No, it's gone. And what we found during COVID is that in England, we're not particularly good at sharing data. We're really, really good. I don't know if there's people from NHS England on the call, probably. Oh, well. We're very good at requesting lots and lots of data be sent off to the centre every day in case the minister gets asked a question. And I said, well, can I have everyone else's data? It's not patient identifiable. I'd be quite interested in building some benchmarks perhaps from it. And I could quantify and compare and age standardise and age sex standardise who's coming into our hospital and which of them have got COVID and whether people from BAME communities are more at risk or less risk. And I got told by NHS England that that data was not for my eyes. As a relatively senior bod in the 6th biggest hospital in the country, with the usual sort of struggles and travails around COVID. So we seem to have an industry of collecting data that we don't then share. So what's been quite interesting is that if you scratch, there's a load of, it's a bit like the Wild West, there's loads of kind of hooligans out there who are quite interested in data actually and publish all of their code openly on GitHub and have created APIs into Public Health England's data. They've done it previously with surveys coming out of Number 10 and all sorts of things. And every week we've done a COVID webinar on a whole load of initiatives. Someone's tapping away on their laptop that might want to go on mute. Catherine. And there's a really interesting movement which probably didn't exist even a couple of years ago, where there's huge data sets which could come out into the open and we could share safely for research purposes. So this is a kind of move for open data out of things like taking the local bus timetable and putting it on an app, which a lot of people do, and is a really great example of data that is not sensitive, that could easily be shared and could easily be presented in a form that's useful to people. So I live in a village which has got a level crossing, and some smart ass has built an app that shows me when the level crossing's down and when it's up, and if it's down, how long it's down for, and it's changed my life. So the $1.99 I paid for it seems like pretty good value. If people like Catherine and I could put together huge denominators of research data through an appropriate IG framework, I think we could do some really, really interesting work through the next kind of 5 to 10 years. So a lot of the research bids I'm in centre around that, which is linking data, agreeing data standards, and that's a really important thing. It sounds really boring, but it's really, really important, and the IT folk won't understand it because it's quite subtle and it's important. So at the beginning of COVID, when we were worried about if everyone had enough oxygen coming out of the pipes, everyone was counting the flow and density of oxygen in a different way, which is balmy. So we got everyone on the phone and just agreed that we would all do it the way that the majority did. And the definition of a suspected COVID patient is really easy to say, but it's actually quite subtle. Is it that did they have a positive swab, or did a clinician see that they had a negative swab but thought they probably were positive, but did or didn't want to commit themselves, and did or didn't write it in the notes of the patient, so no one actually knew. There's quite a lot of subtlety which you kind of need the data people to kind of have a look at. That's a little plug for Open Data Saves Lives. Google it, have a look. If it's of interest, join in. If we go to the next slide, please. Just something else I want to cover over the next couple of minutes, if that's all right, Catherine, then we can kind of take some questions. So this is the sort of last example here, which is, you know, I'm the speaker, so I'll take a kind of lobbying position on most things. We've had over the last sort of 5 or 10 years various guises of digital maturity indexes, and I think you get these, you know, digital academies and all sorts of things. But if you scratch, they're really boring, and they just talk about IT stuff. So they talk about N3 and security, and whether you should use cloud or not, and you know how the NHS should deliver its mail, and whether it should have servers in this country or abroad, or so on. And it just misses. And what they do is they do this very passing reference to what people might call business intelligence or data warehousing or anything like that. So you have sort of a couple of questions in a couple of paragraphs, and traditional sort of IT directors might write a strategy, and on page 57 there's a couple of lines about a data warehouse. What we thought we would do is to bring analytics out of that and to develop an analytical capability index. So if you imagine, if you just go to the next slide, that would be great. And just go on to the next one. So that's it, that one there. So I don't know if you can see all that, but what we came up with through kind of various workshops and kind of talking to a lot of good people that we know, including some people on this call probably, is that you could probably develop a score around analytical capability for an organization. And that might be things like the culture. You know, are you up for sharing performance data? As David Dalton always used to say he would, you know, he would put up a sale board at the front of the hospital saying, this is quite a dirty hospital. We hope that it will be quite a clean one soon. But, you know, come on our journey with us. You can put that sort of data out there and make it part of an improvement journey, or you can, you know, keep it very, very close to your chest until you really have to get your fingers off it and give it to a regulator. So there's something cultural about the use of data. You know, we came up with about 50 questions which can kind of triangulate these different metrics here. You know, have you got a board that always asks for data before they make a decision? Which sounds like a silly question, which sounds like a daft thing, but most of the time they go, well, I've worked in the NHS for 20, 30 years and I came off the graduate management trainee scheme and I kind of know my way around a hospital or a health economy. So my senses will probably do something a bit like this. And it's very, very rare that you get a proper statistical evaluation, to the point where we did one last year on health coaching, which we thought was sensible, but it was its level of being sensible was so far beyond what a lot of other people do that it won a national award for a statistical evaluation, because no one does them. People just put stuff in places and change pathways because they feel it feels like the right thing to do, or it might be a good tactical decision at that moment in time. The more you can kind of bring data into these decisions, the better. So we came up with a series of metrics which would allow you to score yourself on how analytically capable you are as an organisation, as opposed to how digitally capable you are. So you might have the best CIO in the country, and you might have gone through putting in a fantastic PAS and an EPR and even a data warehouse and so on. But if you haven't got really good analysts or an IG framework, or just a group of people who are interested in drawing graphs and animating them, you kind of won't get too far. Conversely, you might have a fantastic analytical team, but you might have a board that will only take a decision if in the top right hand corner it says KPMG or EY or Deloitte, or, you know, pick from one of those, because they then feel externally assured. And I think practically we need to start throwing a few stones around at some of these, because some of you would find that when those people are commissioned, you end up redoing the analysis for them because they've not quite understood the bed numbers and assumed, in one example I saw, that all strokes happened at home. And when we pointed out that some people have strokes when they're not at home, I was sort of chucked out of the room as a sort of a geek who was just trying to make trouble. So I think we need to kind of have a go at some of this stuff. I think if you can get a board that's really up for developing its analyst community, always making data-based decisions, you then need those CIO people to kind of, you know, build you the cloud or the local infrastructure, help you with making sure the data flows real time if you want to show it real time, getting you enough computing power that if you want to do natural language processing, you've got a computer big enough to handle it. So you do need to have to talk to the stiffs in the basement, but try not to do it too often for the sense of your sort of mental well-being. I think if you click through, I think that's me. These slides will obviously go around. There's some links on them, so I hope that's helpful and on time, Catherine.
Yep, the mute button is coming off. Yes, that is. Thank you very much, Mark, for that. So just moving on to the next slide then. So hopefully you can see from that really where this comes together in thinking about an integrated strategy. So rather than having to sit there and deal with multiple demands for, I need some analysis on this, I need a bit of data on that, I need some information on that, which is generally my reflection of the CIO type experience. You have a person to work with who has got a coherent vision, a coherent strategy and a coherent thought about what data they need, what they use, the amazing powerful potential of data to support the development of a system. That sort of vision to come up with the open data, thinking about the workforce and the role of the analysts, and therefore you've got a partnership to come together to really bring that strategy. So the quote, stiffs in IT cannot have to sit there and deal with how many patients are flowing through ED. Well, why does that figure not match the last figure that you sent me on this spreadsheet? And digging around trying to sort that problem out, you can actually think about what you like thinking about, which is the right technology, and also the partners as well about really enhancing some of that capability and thinking about what could we do with AI, what might Mark want to support this, what could Google bring to the picture, and those sorts of conversations. So hopefully you'll have just got a taste from that of how potentially powerful and useful this partnership could be in really getting to an integrated strategy. I'm muting myself, sorry, thank you. So let's take us back to what we've been talking about. So when we're not talking about COVID, we're talking about population health management. And so the question is, so what? So how does this help me with my population health management problem? Okay. So it is absolutely clear that if you are going to get to grips with the ICS strategy, with the demands of phase 3, with getting that holistic approach around a patient and treating the needs of the wider needs of the cohorts of the patients, you are really going to have to understand your system, and that means you need an intelligent driven system. So my reflections on this is that your PHM strategy, however, it is only really going to work if you are harnessing that progress that you've had with technology, bringing patients on board, increasing access for clinicians, increasing technological capability of your staff, right down from the board to your clinicians, to the patient on the ground, that you are creating the idea of, I would say, call it a hive intelligence, where people have on their phones the information they need and they are sharing it, and they are using the intelligence to drive a common picture and a common understanding of what the challenges and what you need. Integration. You really need to, from the CIO point of view, the stiffs in IT point of view, we need to join this up, which means we need to think about how that strategy to do that. And it's only going to work if we've got a workforce that's digitally empowered and, as we say, data literate. And that might mean you need to be sitting alongside your analysts who are helping you navigate your way through that information. But it is certainly something that Mark has highlighted with the analytics capability framework that needs to be thought at all levels, right from the board, not right to the clinician, right to the people on the ground. And from my point of view, Stiffs in IT, you need the right tools to do that. So I need to make sure that Mark and his team have got the right tools to empower and enable them, as well as the clinicians on the ground. So I think all in all together, this is where I think the strength of that will come together. And this is what I hope will make a massive contribution to the development of PHM over the next 5 years. So I hope hopefully we're sitting here in the next 5 years, and I'll be sitting there will not just be the one little IT stiff person, there will be the CAO probably sitting here doing all of this, and I can wander off and get back in my basement again. So hopefully that's given you an idea and some taste to think of. Just move on to the next slide. We'll just so I'm going to open the floor. So there's a couple of things. I'm going to open the floor for questions and answers. If you're like me, where you won't think of a question now, but you'll definitely think of something later on after you've had a little digest time, please come back to us. Mark and I are constantly in conversation on Twitter, so please follow the conversations going on there. There's some very interesting threads, particularly about what we're doing on the Digital Week and also with the open data as well. And we will be fleshing this out in more of a paper, which hopefully you can take to your board and use as building your case for why you should be developing these this role and these skills. Okay, so what have we got on the questions? So let me have a look. Right. So we've got a question via email that's come in. Thank you, Nikki, for sharing that. So Mark, this one's for you. And I think I'm going to ask you, Mark, for this, because I've probably got my own views on this. What's your view of the new Chief Digital Officer role? We've talked about these roles coming up and proliferating, becoming very popular, the Chief Digital Officer. How do you think it would interrelate to the CAO?
I think that advertising of Chief Digital Officers is quite a lazy decision, and I think you've got some big kind of monolithic hospitals, STPs, ICSs. You've got some trusts that are kind of working together on putting roles out there jointly, which I think is a good idea. But my overall view of this is that it's quite a lazy decision, and it just sort of groups together things that you don't really understand enough about. And I think the people that advertise for people for those roles listen to you and I at conferences and think, I'm not quite sure. They seem to get on quite well, actually, and some of it sounds the same and some of it sounds different, and they have, you know, similar but different views on a variety of things, and I don't have the time or the understanding to split those out. I'll give you a really quick example. So we've set up a data science group, only very fledgling, and we've split it into advanced analytics and applied analytics. So applied analytics, to my definition, is taking a technique that already exists and using it. So that might be regression or segmentation or neural networks, machine learning. You know, with things like machine learning, you start to drift into what I would call advanced analytics. So that is kind of, you know, to some things you're alluding to with, you know, that Google DeepMind do and others. That is machine learning and natural language processing and of the new. And it's a subtle distinction, but I think quite an important one, because for applied analytics, you're simply teaching someone things that already exist. And for advanced analytics, you're giving them the creative space to go and build something new, and you then have to really make sure that that model or that algorithm doesn't discriminate against a particular ethnic group or an age or a gender or something like that. And that's quite a subtle distinction, but I think it's a really, really important one. And I think the people that put job adverts out for chief digital officers, they just don't want to do the detail on that. And I think I've, you know, I mean, through presenting, I'm, you know, deliberately kind of exaggerating to make a point. I think the conundrum it leaves you with is whether a chief analytical officer is part of a digital gang of people, you know, with people like Catherine and I sit in the same board, or would one or both of us sit in a different board, which was, say, a population health one. And I think I would have a view on that, but I would also be pragmatic and say it kind of comes down to who you've got and who's in the region. But with any description, whether it's chief digital officer or your use of the term informatics, which is it's just a weird word, I just think we have to kind of be really tight on the language. So I generally don't approve of it, and I'm generally making an argument for more subtle roles. There's plenty of work for everyone to do, so just describe it properly instead of just putting it all in a bucket that's a bit too difficult.
Okay, thanks very much. Well, said like a true analyst is all I can say. In the detail, you've got to stick with the detail of the description. You've got to be exact about it. Having run a team of 180 analysts, I know I have now learnt my lesson. Do not get the language wrong, or do not fudge your language. Another question that has also come to mind, and this is a vexed one, and it's always the hot potato of the two-word term that everybody runs a mouth on, but does need to be tackled: information governance and access to data. Now, we know between us from all our work that it's critical at every level. It is so important that we get this right, because if we sit on the silos of data and we don't use it, at some point we're endangering lives, and that's my firm belief. But in all of this, in thinking about those two roles, where does that responsibility sit for unlocking and getting the governance right over that data so that we can share it and you get the benefits from it?
Yeah, I completely agree with that, as you know, and I think the point that you and I have made through the last hour that I hope people will agree with is that the landscape is vast. So you need experts in different areas. So I absolutely would not want to be responsible for IG because it's very subtle. I would though want to be involved in making the ethical arguments around the use of the data. So the COVID COPE extension, I think, is really good. And my view of what the government are doing is saying some good things have happened actually. So why don't we just let it roll for a while before we kind of try and tighten all the processes up again? Because I haven't met anyone yet who wants to use data for bad. There'll be someone out there, but I think it's too lazy when we all go, oh, this is very difficult in terms of IG. It's very difficult in terms of IG. Well, which of the 20 people in the room are going to sell it on the dark web? Because I don't think any of them are. I think they all want to work out if this group of people are more at risk of this disease or not, so that we can design a new patient pathway. And as part of that Open Data Saves Lives initiative, one of the 4 things that we're standing for, one of the 4 pillars that we're kind of writing as a strategy, is to present the argument for strong information governance in favour of using it and linking it, as opposed to always going, well, this might be really difficult in terms of IG, because that's a really easy and lazy decision to make. It's a much braver one to say, do you know what, we're going to do this stuff with the police. Actually, it's going to be all right, because I can sleep at night having done it, and I would happily defend it in court. And it's an ethical argument, you know, by absolutely do the law. But if you look into the legal side of it, the language becomes quite loose the more senior you get. You know, it's about reasonable use and proportionate and all of that. And I'm comfortable making an argument that that's appropriate.
Yeah. Okay. That. I think, you know, I agree with you. It's a mantra that I think we all need to pick up. IG can be difficult at times, but largely what you want is you need to hearts and minds conversation. You need to get your stakeholders bought in and involved. It might look tricky, it might look complex at times, but it is never undoable. And it is something that a lot of people, I would agree, tend to sort of put in there, oh my God, it's far too difficult box and run for the hills. On another, and sort of, you know, the floor is yours on this. What would you see, you know, I know you are now Chief Analytics Officer in Kenton Medway for the new ICS. What do you see as your sort of, what's your vision for that system? What is it that you want to achieve? Or I asked you to 48 hours into the role, and it's a bit early.
Well, we've written a strategy. Which I'd be happy to share if people get in touch, or I can send through this group, which tries to set that out. And again, it sounds sort of pedantic, but we've written an analytics strategy for the region, and it links unwanted variation and unwanted health inequalities to potential improvements through the use of data. So we've centered largely on those two things: inequalities, unwanted variation, unwarranted variation. And there's the level, the strategy exists at a couple of levels. So there's it's a quite nice glossy document which sets it out, but I've also got a much more detailed but slightly drier document which has got project plans and all those types of things on it, and I'm very, very happy to share it. And I deliberately wrote it because no one asked for it. There'll be a dull old digital strategy knocking around probably that's just been copy and pasted across the country. But we wanted to write something that was about the use of data. And the vision, one of the points of the vision is to try and develop a reputation locally for just being really interested in data. So we've got a medical school opening, we've got good universities, we've got a relationship with Pfizer and Discovery Park. So we've got virtual reality and augmented reality that we can tap into. We've got good relationships with EMIS and GraphNet and Microsoft and others. And our vision is to develop a reputation for being really, really into data, because if you do that, good things will happen out of it, because people might want to even come and work with us and live there and start startups there. So it's not a kind of a tick box for data that a lot of places will have done. We really want to create a reputation, as you've done really well down there. I think it's a big opportunity in Kent. We've got a nice clean data set because we're surrounded by the sea. We've got good relationships. I think we could do something quite cool.
Yeah, okay, yeah, definitely people would like a copy of that strategy. So if we can share that or put something out on Twitter, I'm sure Mark's happy to do that. So how do you, have you thought about, or what would you say your key, I was going to say not activities, but what is the thing that you're really focused on at the moment in terms of, because I'm just thinking about a lot of people in this position. I've been in this position. Your ICS is forming. You've got a number of the CCGs emerging. Everybody has come together brilliantly around COVID. The NHS has been astonishingly good as always on this. What is it that you are focusing personally on the moment in terms of driving this vision? How are you going about it, and who are your key people that you think the ICS need to be on board with this?
So 3 things: get the IG framework in place through joint data control under GDPR, get a shit hot linked data set that's deep and wide, so it's got clinical data in it and it's got data outside the NHS in it. And then the third element is to get a group of people, we'll call it KMAP, Kent and Medway Analytics Partnership, to analyse it. So I think we've done the first one. I think the IG framework is in place. We've got an ethics committee at the university. We've got a board that I chair, and we've got joint data control being put into PCN constitutions. We're in the process of building the kernel, which is a new linked data set, and we're in the process of making a business case for a local analytical team to reduce the reliance on management consultancy. What those 3 things mean practically and politically for me is to just kind of get around the people that need to think that's a good idea, because the risk is that people who do your type of role just hoover up all the money buying computer systems, and there's none left on the table for the actual analysts, because it's really easy for you know, usually 60-year-old men in suits to just drone on making big old IT purchases and feeling quite macho, and there not being much, there's just a few crumbs for us to buy Power BI with or something like that. So we just need to make sure that the digital money that flows from the centre, if it's called that for better or for worse, doesn't just go on buying tin and SQL licenses.
Okay. I'm going to reflect on that as well, because of also having you know, the fact that we've got an active programme that we're working on with you, or I've got a small programme I'm working on with the Kent CCG and working with yourselves. I mean, the reflection that I would have on this, and I totally agree with you, is what you can see by putting this in the technology space and not thinking about it from the analytics space is you see a lot of duplication across these systems. So and that worries me intensely. I'm sure it worries a lot of people about the real value for money here that you're buying it, because you can see a lot of these digital technology platforms being built in that are duplicating what they actually do. So you're duplicating the data. In some ways, you're duplicating the effort of pulling the data across the system for essentially without thinking about what that coherent strategy is around that data and that analytics, and therefore that should be something that you need to take into account when you're thinking about your technology strategy. You can't, I feel really strongly, you cannot do these things in isolation, because if you do, you'll end up exactly like you said. You will spend an awful lot of money on buying a platform, and you will not spend the money that you need on getting the intelligence out of the back of it. That will all, and I have seen this previously, it almost comes as an afterthought, and that absolutely shouldn't be the way that that's going, because if you don't invest in the right tools to get the intelligence out, I think you are going to miss a trick there. And on that note, I think we've come to the end of our time. Am I correct? So she's looking desperately well. Mark, that's been really fascinating. Thank you for spending the time with us. Thank you for, as I say, clearing my head and making life easier. And can I encourage everybody, thoughts and comments, please join us on the conversation on Twitter. Please don't hesitate to get in touch with us again. We will be sharing, I'm sure Mark will share links to the strategy, I'll be sharing the slides.
Thanks, Catherine, really enjoyed it.